Good afternoon, everybody. We are going to be try to be very entertaining on this panel. We know it's the last session of the day, and it's sometimes hard to sit still and listen, but I have to say I'm so pleased and honored to be asked to speak to you all today. I actually really wanted to come last year, and I was not able to, so really happy I'm here with you today. And just based on earlier today conversation and just talking to some of you all at lunch, just really impressed by this gathering, by what you're trying to do here in California, the interest level of you all here, and so I hope the information I share with you today is useful. My goal today is to talk to you a little bit about what's happening at the governor's level. So I have been in Washington, D.C. for over 20 years, and I'm at the National Governors Association for the past 5. And those of you that are not familiar on what NGA is, it's the oldest organization serving the nation's governors. And this is actually a picture of their first convening with Teddy Roosevelt in 1908. And I will tell you, it's not very diverse. So you know, we're working to change that. And I wanted to talk a little bit about just who the governors are and what they do, because I don't think, just reflecting on the earlier comments of today, that it gets a lot of press in the media. You know, you hear about probably your governor here in California, but it doesn't necessarily translate. Okay, what are governors doing across the country? And what we do at NGA is really convene them, all governors, from the Democratic Party and from the Republican Party. We are completely bipartisan, and we convene them, and when we convene them, they actually have a lot in common. They really work together on different ideas in healthcare. You know, I've been in Washington, D.C. a long time. I worked in the private sector on healthcare, and then I went to the federal government. And, you know, healthcare, especially since the Affordable Care Act, has been very partisan. And certainly that is true when you live in Washington, D.C. But I am heartened every time I go to work at NGA because there actually are governors working together across party lines within their state and across states. So I want to talk a little bit about what they're doing, what the priorities are, and then specifically focus on cost and value, because I know for this group that's what's most important. But a couple of things just to talk a little about the governors, just reflecting on Norm's comments, which was an incredibly amazing and depressing conversation, food for thought. There were 22 new governors in 2019, and not everybody is kind of aware of that because it doesn't get a lot of press, but we focus a lot of our time and attention on that. That's almost half the country had new leadership. That's important because new governors come in with a lot of new ideas. They work with their legislatures, and unlike at the federal level, they have to get things done. They have generally 1 or 2 year budgets. They have to balance those budgets. And what that means is when you may have a Democratic governor and a Republican legislature, they actually end up working together, and they have to come up with solutions, which doesn't always happen at the federal level because they don't have that pressure to pass a budget. So a couple things I just want to highlight for you in terms of new governors. We had a wave of female governors, which I'm particularly proud of to see. We have now 11 female governors, which includes 2 in the territories. So that's a significant increase, believe it or not, from what we had from a couple of years ago. And it's interesting because there is definitely, I think, energy amongst female Democratic governors. So we had new governors in Michigan, Kansas, Maine, South Dakota. And Oregon and Rhode Island were reelected. So I think it's been interesting to watch them coalesce and work together, and that's something I wanted to share with you all because it doesn't always get a lot of press. I think the other thing I would say is governors don't always focus on healthcare. There are many of them that do not have a healthcare background. They come in for different reasons, but a lot of them have talked about healthcare in the campaign trail. So it's interesting to see them come in and then try to actually implement some of what they have promised on the campaign trail. It's in Governor Newsom, as you all well know, he has been big on healthcare, a lot of executive orders coming out, a lot of directives. His predecessor, Governor Brown, was not so healthcare focused. So we've been watching carefully and working with his team on the different ideas that he's been rolling out. But it's been true for some other governors as well. Healthcare is the tough nut to crack. You know, all of them are focused on job and economy. But then they can't kind of leave healthcare alone because of the voters, frankly, and also because of the impact on the budget. So those driving forces have really brought healthcare to the forefront, and from my perspective, have brought some governors that may not be so focused on healthcare or may not want to be so focused on healthcare have to really take an interest in it. So I share that with you. Okay, just a little bit about background about NGA and where I sit. So there's two parts to NGA. There's the Office of Government Relations, which is really the lobbying arm, and then there's the Center for Best Practices. And the Center for Best Practices is really a think tank consultancy for governors and their staff, where we bring together all the different ideas from all the different states, like who's doing it best, how can you model that, how can we support you to move policy forward in a completely bipartisan way. And so I share that with you because all the remarks I'm going to make today come from that work that we're doing with the states. And oftentimes it may be a Republican state that has a great model, let's say, with syringe services programs. And Democratic and Republican states model that Republican model state. So it's something that I think is the federal Congress could learn from. I really do believe states are laboratories of democracy. There are a lot of things percolating at the state level that I think can and will rise up to the federal level, and hopefully we'll be able to see some of the things that we can do at a national level in the future. Okay, I can skip that. Okay, so a couple things I just want to talk about in terms of what the governors are focusing on. These are the big, broad topics. I'm going to spend most of my time on the first one, coverage and value, because that is, I think, what is most interest to the folks here in this conference. But I just wanted to also give you a snapshot of what else is coming to the top of the list. Opioids and addiction, since 2012, that has been a top priority for governors, unfortunately. I would say their priorities have shifted in the sense of we're not really talking about opioids anymore. We're now talking about polysubstance use. Meth has come into many markets. There is complicating factors about people on different types of opioid plus and illicit substances, and the deaths that the states are seeing going down on average on the opioid side, but going up with some of these other substances. So I do think governors still feel like they haven't got their arms around it. So we are certainly spending a lot of time working on that topic. Public health, infectious disease, vaping, and vaccinations have been really hot topics this year. I know you all have been hearing about the coronavirus. We just actually had our NJ winter meeting where we brought all the governors together. There were 46 of them there. We had a briefing by the federal officials on coronavirus because of the need to get information out. But we also had a session on vaping. There's a lot of interest at the gubernatorial level of what they can do on vaping. Absent federal action, there was, the ban on the flavors, but a number of governors feel like it didn't go far enough. So there's interest in what they can do at the state level to take that to the next step, to really think about how to protect the youth in particular. Vaccinations, there has been sort of a reaction to the measles outbreak, and so there has certainly been a lot of interest at the gubernatorial level of what can we do by executive action to address that, and work with our legislature to actually think about how to better address vaccination rates and get folks educated on what they need to do. So that is another thing that we've been focusing on as well. And cannabis is coming up quite a bit. In states that are looking to legalize it, but also states that are just having it as medical use. So something that we will be focusing on. Behavioral health and social determinants of health, always and consistently a big topic for folks out in the different states. I think behavioral health is something that's so important but also very challenging at the same time. And social determinants of health has morphed in different ways. Housing, transportation, food insecurity, these are all big things where we've been working with governors on how to really get their arms around programs. And I will say the term SDOH, 5 years ago when I started, there'd be some governor staff that were like, I don't know about the social determinants of health. What does that really mean? It's come a long way in the past 5 years. There's really been, I think, an evolution of thinking on that and a real buy-in to understand that we have to invest in these other areas in order to really improve the health of populations. Data-driven policymaking. I call it the stepchild because who wants to talk about data all the time if you're not a data person? But it's so important to the underpinnings of all the things that we want to do in, payment reform and delivery system change and even behavioral health and social determinants. So we have spent some time working with the folks in the governor's office on data and how you think about data more effectively and how you can really learn from your data to really promote good policy. Healthcare workforce has also been a really big topic for folks. And we have spent a lot of time thinking about how do you think of not just scope of practice laws, but investing in how you have the right workforce for what's going to change in your population, including your aging folks, and how to have the home health care workers that you need and and the like. So that one I think will continue to be a topic that we will work on for many years to come. And of course, last but not least, aging and long-term services and supports. And I would say for that one, not all the governors are talking about that. Probably a small minority are, but from my view, a very important topic that we cannot take our eye off the ball on, because the populations are shifting and we really need to think about our systems, not just in healthcare, but across all the systems of aging and all policies, and really think about how we embrace that population so that they can be supported in the way that they need. Okay, so I'm going to talk about coverage and value, and Kristof's going to tell me when I run out of time. 10 minutes, okay, all right. So one thing I want to talk about is the bulk of my talk is focused on how we actually do things at the state level, because there's been a lot of action, but I think states and governors recognize that they can't do everything, and so there's some areas where they really need to have Congress step in and help. And so earlier in 2019, the governors came together and actually released principles for federal action to address healthcare costs. And I'll just say this as a reminder, this was a bipartisan effort that got sign off from all the governors. That is not an easy feat to do in healthcare, and almost unheard of at the federal level. So if you're interested, the document is on the NJ website. Feel free to go and look at it. But just at a high level, surprise bills. So I'm going to talk a little bit later about, at the state level, what states have been trying to do. When that consumer walks into a hospital that they think is in their health plan and covered, and they get a surgery, and the anesthesiologist wasn't in their network, and then lo and behold, they come home, and here you go, here's the bill for the anesthesiology services. Big surprise. So that has been something that governors have been hearing about and really have gotten activated on, along with their legislatures. So the challenge is that they cannot regulate ERISA plans, which is a big part of their markets. They also cannot regulate air ambulance, which has also been a challenge in terms of cost and the balanced billing for consumers. So I think there was a push from governors and their offices to include surprise billing in these set of recommendations for Congress to act. So, it was great to hear from Wendell to hear that they are thinking about putting surprise billing into the extenders hopefully in May, and hopefully that'll all come about. But we are very supportive of that because of limitations of what states can do. They can only regulate so much, and those are things that fall outside the market. Balanced pharmaceutical access and costs. So I'm going to talk a little bit later about all the things that states are doing on pharmaceuticals, and it's a lot. And you heard, I think, a wonderful presentation on that, so I won't go too far in detail, but I do think there are significant limitations for what states can do, and I think the states know that the big levers are at the federal level. So again, heartened to hear that maybe there's some hope that some progress is made on pharmaceuticals in Congress, and we will wait to see. But in our recommendations, we talk a little bit about the need for a national standard for transparency and pricing and payment for pharmaceuticals. We talk about accelerated market entry of safe and effective generics and biosimilars. These are things that states cannot regulate at a national level across all the states. We also talk about state flexibility. So one thing that didn't come up in the pharmaceutical panel is for states, they have the grand bargain under the Medicaid drug rebate program, where in exchange for getting a deep discount on drugs, they have to cover all the drugs that are approved by the FDA. So unlike a commercial insurer, they can't choose to say, okay, we think these 3 drugs have efficacy and are great, but we're not gonna cover the 4th. They have to cover all of them. And that's because in exchange for that, they get their discount through the drug rebate program. States have felt hampered by that. They've seen the benefits and they've saved lots and lots of money on that over the years. It's true, and I think because of that, Medicaid has some of the lowest prices on drugs. But they also have limitations because states do have limited budgets, and they have to balance their budgets every 1 or 2 years, depending on the state structure. So one of the things that we asked for in these set of recommendations is excluding from formularies some of the fast-track drugs that are first in class that may not have the evidence to show that they will be fully effective until that evidence is produced. So that's certainly something that I think a number of states are interested in being able to have the flexibility to do. Massachusetts actually requested that flexibility, not quite worded that way, and was not quite denied, but was not approved by the Centers for Medicare and Medicaid Services. So, states, I think, thought maybe that's a signal that we can't do that. And then I think we had the opportunity through guidance from CMS that states could choose to have the ability to exclude from the formulary, but give up the entire drug rebate. And so states don't want to have that bargain. I think they feel like there's too much at risk there as well. So we are interested in new ideas of what can be possible with the exclusion. There is some new opportunity with block grants. And I know we're not going to spend a lot of time talking about block grants today, but the states I've talked to so far feel like there's too many other risks to then think about the pharmaceutical piece in the context of a block grant. So that's something that's very interesting. A lot of states also are really interested in importation. So in our recommendations, we talk about having demo opportunities for importation from Canada, and of course there's been guidance out on importation, and comments are due, and states are also passing their own laws. There's a lot happening on that front, but I want to mention that as well. And then the rest of our recommendations talk about dual eligible opportunities. So really thinking about how do we, for these complex, high-cost populations that are eligible for both Medicare and Medicaid, how can we do better? How can we bring programs together to coordinate and better serve the population so we save money but also improve outcomes? And CMS has released some new demonstration opportunities, which are wonderful. The states, I think, still would like to have more opportunity for shared savings. So if in fact you do a good job to integrate care and you save money on the Medicare side because they don't go to the hospital over and over again, what's the opportunity for the state to have some of that back? So that's definitely something we also asked for. Okay, I'm going to keep going. So Medicaid expansion. Before I get into some of the other cost and value, I want to just reflect for a moment on Medicaid expansion, because I think it's interesting to just look at this map. And, since 2014, 37 states, including DC, have expanded Medicaid. And it's over the last year, we have seen 3 Republican states who expanded Medicaid or almost expanded Medicaid through a ballot initiative, where the voters decided they wanted to have Medicaid expansion. And that's Nebraska, Utah, and Idaho. There is going to be more action, I believe, on Medicaid expansion this year, so it's something, if you're interested in, I would strongly encourage that you pay attention to. And there have been, as I mentioned earlier, new Democratic leadership in some states, which has triggered some interest in states like Kansas, where the governor is working very hard. It's her top priority. She campaigned on this to expand Medicaid, and she's working with a Republican legislature to try to get that through, and we'll see if that happens. There is definitely some challenges there. In Oklahoma, conversely, we have a Republican governor, but there is a ballot initiative underfoot where there is an interest in amending their constitution to provide for Medicaid expansion. So right now it's polling very high. The voters seem in favor of it. We will see if that actually happens, but again, something that can move in that state. And the reason I wanted to focus on this map is you'll see the Southeast. That is where there has certainly not been Medicaid expansion. In North Carolina, the governor, again, Democratic governor with a Republican legislature, really top priority for him, Governor Cooper, to expand Medicaid. He is hitting roadblocks with the legislature at the moment, and they're in standstill over the budget. So we'll see if there is movement there. But these states are going to have and continue to have some real healthcare disparities, and especially in some of these states, have some challenges with their health outcomes. And Medicaid expansion and the lack thereof is going to continue to be a challenge for them. So we will see how that plays out as we move along. And I think the comments that we heard earlier about the Affordable Care Act, if you think about if the Affordable Care Act actually goes away, so does the Medicaid expansion. That is part of it. And what does that really mean across the entire country? So for all of these folks that are covered under that program. Okay. All right, so let's talk a little bit about the cost and value pieces that we're working on. One thing that's been really interesting for me to experience is when I first got to NJ, there was always a focus on Medicaid and state employees. That's sort of the traditional bread and butter. Governors have to worry about those two populations along with corrections. They're big budget items. They always, often eclipse sort of the other spending on the state side. And, everybody thinks about how can we do those programs more effectively? How do we better provide health care? Interestingly enough, because I think of the movement towards more plans where there's high deductibles and consumers are feeling the cost of healthcare, and I think we heard about that in an earlier panel, there has been more pressure at the gubernatorial level to do some work on the private insurance side. And so I think, for example, surprise medical bills, as I mentioned earlier, has come to the top as one of the things they're really interested in. So I share this with you, this map, because 28 states have actually passed comprehensive or limited consumer protections against surprise billing, and 6 of those states were just in 2019. So this is definitely a movement, and you'll see it's red and blue states. It's not just one. It's really not political. And I think one of the things that has been a challenge has been you can prohibit the out-of-network providers. Oh, am I done already? Oh, okay, I'll go really fast. I'm going to do it in like 2 minutes. But the challenge is, how do you then have the benchmark of you can't actually reimburse over a certain level? That has been definitely, I think, the fight in state houses. Or do you just default to independent dispute resolution? I better keep going because I can't talk anymore. Okay, the other thing too that's been coming up is reinsurance, so stabilizing the individual market. So as you can see here, there's 12 states that have reinsurance programs through Section 1332 waivers, something that we've been working on with a number of them. And it's really an effort to lower insurance premiums by offering coverage of risk for the insurers and increasing enrollment. And I would just say there's been a range of the impact of those programs. In Alaska, for example, premiums were reduced by 34% in the first year of enactment because their premiums were so darn high and they only had one plan. In contrast to Oregon, where it was only reduced by 6%. So it really is market dependent on how things are happening in their state. Okay, I can't not talk about public option for 2 minutes because I know it's something of interest for California. So I just want to talk a little about the 2 states that have actually done something on public option. Washington was first, and they passed legislation which was really tough for them to get through. We worked with them. And they're planning implementation in 2021 through Governor Inslee has been leading the charge on this. And they're going to contract with private carriers to offer state-sponsored standardized health plans on the exchange. The kicker is that providers will be reimbursed at a maximum of 160% of Medicare. And that was actually a very, very tough negotiation for the folks in Washington State at the legislature level. I think the challenge is there's no requirement that providers have to accept that payment rate, so it'll be interesting to see if the plans are able to actually build adequate networks. In contrast, Colorado, following them pretty closely, is planning implementation in 2022, and they also will have the standardized plans and contract with them directly. They, in contrast, will raise required medical loss ratio to 85/15 for plans, and providers will be reimbursed at a set rate by hospital-specific formula. So not quite the 160% of Medicare. It's actually a range. I think it goes up to 225% of Medicare because the rates in Colorado for hospitals are so high, some of the highest in the country. So something to watch as California thinks forward and moves forward on expansion. Okay, so I'm not going to spend a lot of time talking about pharmaceuticals because you've heard a lot about it. But I just wanted to say for you to know, ton of activity at the state level. Even though they know that their big levers are at the federal level, they feel like they have to act. The voters are asking for it, the governors want to do things, and so does the legislatures. So I'll just say briefly, it started with transparency, where there were 17 bills enacted in 11 states, including here in California. And then we have moved on to things with pharmacy benefit managers, where, just so you get a sense, 40 bills were enacted in 2019 across 27 states, addressing PBM transparency, spread pricing, et cetera. And then there's also the pharmacy carve-out piece, where there's a number of states thinking about what to do with carve-outs. There's 6 states with managed care programs that have carved out pharmacy, and there's more thinking about what's coming next, including California. The other thing I would just say is reverse auction in New Jersey. If you haven't, looked at this, I would encourage you. It's an interesting model. They actually have an approach to procurement that helps foster competition among bidders towards the best offer and lowest price for their PBM vendor. And they spent $10 million to set up this really complicated procurement process where they actually view the bids against the claims, so you can actually see what the cost is based on what the bids are for the PBMs. And they have saved $1.4 billion in 1 year for their state employees. And they're projecting a $2.5 billion savings by 2022. So they have seen a lot of savings for their state employees, and they're very pleased about it. So we've been spreading the word with other states about this model and educating them. The other thing I'll say is just on importation, which is not on here. 4 states have enacted laws: Vermont, Florida, Colorado, and Maine. So it's something to watch. A lot more interest from states on what to do next on that. And then alternative payment approaches. So one thing to look at is Oklahoma, Colorado, and Michigan have worked on value-based purchasing. That's the term that they're using, which is really outcome-based models of, okay, we'll give you money back if you don't actually prove that your drug worked with the following outcomes. I think other states are looking and watching to see if they're actually going to glean savings from that, because there have been, I think, some challenges around sort of data analysis and how they're actually setting those targets. But more to come on that. And then there's finance-based arrangements in Louisiana and Washington where it's more about, okay, this is the budget we have for, and this was in the Hep C context, for serving this many people and providing them with Hep C. We're going to continue to provide that budget to you, but we can have a larger and more unlimited set of supply of Hep C to treat more people. So at a very basic level, because I don't have time to kind of go into the details, that's what that is, and I think other states are looking at it. And finally, I would say we are watching California closely to see what happens with you all with these establishing a single market for drug pricing. A lot of states are interested to see what you do, and creating your generic contracting program. And I think that governors are very interested in what happens in California, along with all of these other pieces to really determine how do we pull this all together. Do we actually come together and have a bigger sort of negotiating power, states come together, or is it better if we try to influence what's happening on the federal level? I think these are all questions that some of them are asking and will continue to ask as time goes on. So with that, I will stop. Okay.